ஆமா. ஏற்கனவே சும்மா வந்து கேட்க மாட்டேங்கிறான்.
Good afternoon, Rajeshwari ma'am.
Good afternoon, ma'am.
Yeah.
Good afternoon, ma'am.
Yeah, we'll start sharp at 2 p.m.
Sure, ma'am. Sure, ma'am.
மேம் மெயில் பண்ணிருந்தாங்க இந்த
Mahalakshmi, Shanmuga Sundaram, Dinesh.
Yeah, Bhavani, shall we start?
Yes, ma'am. Good afternoon. Yeah, very warm welcome to all in this auspicious scene. Let us start this webinar with the word of Tirukkural. நோய் நாடி நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்புச் செயல், which means let the physician inquire into the disease, its cause and its method of cure, and treat it faithfully according to the medical rule. This webinar event is a small celebration to learn new and small things we have taken towards spreading medical knowledge to other in medical registry and creating cancer awareness. Prayer is a link and connect us with the God. Takes away negativity and boost our energy. Let us start with the Tamil Thai வாழ்த்து. Good teacher not just teach the subject, but also shows us where to apply. I'm glad to introduce pillar of knowledge, one of the convener of this webinar, Professor Dr.PL.Chithra ma'am, HOD in charge, Department of Network System and Information Technology, to deliver the welcome address and introduce our resource person of the day.
Happy afternoon, everybody. On behalf of the
Not audible, madam.
mute, ma'am. On behalf of the Department of Network Systems and Information Technology, University of Madras, jointly organized with MHRD RUSA 2.0 Biomaterials, a one-day webinar on bioinformatics for healthcare. We are happy to welcome you all. First and foremost, I'm happy to welcome our dynamic Vice Chancellor, Professor Dr. S. Gauri, for having given support throughout this program. It is my pleasure to invite and welcome our dynamic registrar, Dr. S. Elumalai, University of Madras. It is my great honor to welcome the overall coordinator, Dr. Professor N. Madhivanan, for his support. Then I'm happy to welcome the captain of the ship, Dr. S. Balakumar, for his entire support throughout this program. So we are going to start this program today. And I'm happy to welcome our eminent resource person, Dr. S. Rajeshwari, MBBS, Senior Consultant, Preventive Oncologist, Clenilage Global Health City, Chennai. Welcome you, ma'am. And she is going to enlighten with another 3 hours to go with bioinformatics for healthcare, specifically cancer aspects, then cancer registry, and how the cancer research could be utilized by the researchers from Department of Computer Science and our own colleagues. Let us happy to welcome you once again, ma'am. It is my great pleasure to welcome all the professors of our own university and professors from other universities across all over India. It is my pleasure to welcome my own colleagues, Dr. M. Swarnam, Dr. B. Lavanya, Dr. Gopinathan, and our professor and head, Dr. P. Tangave, for this program. It is my great privilege to welcome all our research scholars, PG students, and participants, active participants, for taking the great input out of this program. Once again, I welcome you one and all present here. So let us have a fruitful 3 hours time with the great input in bioinformatics for healthcare by our eminent speaker. It is my inbound duty to introduce our eminent resource person, Dr. S. Rajeshwari, MBBS, Senior Consultant, Preventive Oncologist, Corpus Duty Specialist in Global Health City, Chennai. She is an expert in giving lectures and awareness sessions on cervical and breast cancer, creating general cancer awareness. Ma'am has involved with giving awareness sessions on adolescent health to school and college students. Doctor has conducted colposcopy camps and breast cancer screening camps in private clinics with their collaboration. Ma'am, we are honored with your presence. Your eminence will help us to get the great input in this occasion. Conducting colposcopy camps for women staying in NGO homes, in villages, in collaboration with NSS students, maintaining statistics, data analysis, and cancer registry, digital healthcare. Ma'am has completed her MBBS during June 2001, Tamil Nadu Dr. MGR Medical University, Government Stanley Medical College. DNB OG has completed during December 2006, Department of Obstetrics and Gynecology, Vidya Hospital, Chennai. Ma'am has got a various research experience starting from junior resident, pediatrics, Department of PIMS, Pondicherry during 2003, then pediatrics department, CSI Rainey Hospital. Then she has worked under Chettinad Hospital and Research Institute, and she is a consultant in Jeevan Clinic, Kanjipuram, and the list goes on. She is a Pride recipient award of first prize, poster presentation in NUGO Coimbatore during May 2006. Second prize, oral presentation. She is a pride recipient, young recipient, scientist award, AGOICON in AIDS, New Delhi during December 2006. Presented free paper in AICOG 2019, Bangalore on the topic, a collaboration model to promote affordable, accessible and quality cervical cancer screening. She presented e-poster in various cervical cancer and call for action. Then she has got a special training on nanotology, urology and antenatal and gynecology departments. She has been given training course on early detection and prevention of cervical cancer, Parshi, Maharashtra, under the guidance of Dr. Sankar Narayanan, past head of screening, IARC. So, ma'am is having such a wonderful experience. Let us listen to ma'am. Over to Dr. Rajeshwari.
Thanks for the warm introduction, madam.
Hmm.
Good afternoon, one and all. Good afternoon, all HODs, professors, and my dear students. Let's go on to the topic. Madam, you stop the screen.
Yeah.
And start.
Stop. Share.
Can you see?
Yeah, visible, ma'am.
Yeah.
Slideshow you can put.
So good afternoon, everyone. I'm Dr. Rajeshwari.
All the Vidyaji. Okay.
Yeah. Good afternoon, everyone. So I'm Dr. Rajeshwari. I'm basically a obstetrician and gynecologist. And due to my interest and passion in preventive oncology, I got trained in that. Now I am working as senior consultant, preventive oncologist and colposcopy specialist in Clinical Global Health City, Chennai. So in this first part, we'll have two divisions. First, let's talk about like cancer awareness. Then I'll talk about cancer registry in India. So can I make it interactive, madam? Somewhat.
Sure. Definitely.
So all like what you feel or think when you hear the word cancer. Can anyone represent?
Uncontrolled growth.
Uncontrolled growth. What you feel? Uncontrolled growth of abnormal cells. What do you feel? Hearing the word cancer. Any representative? Anyone? So it is an abnormal growth of cells. Abnormal cells. So normally when we born, we grow. Normally cells multiply and we grow. Whenever a cell abnormally grows, it becomes cancerous. It might be due to any chemicals, harmful radiations, or any microorganisms like HPV like that. So there are numerous agents causing cancer. Put in a nutshell, it is like chemicals, alcohol and smoking are one of the most important things, and sunlight exposure, hormonal imbalance, obesity, air pollution, radiation and viruses. So this is how normal cells multiply. When in between any normal cell, abnormal cells grow, they capture the blood and they start growing. So it becomes cancerous at that site. Any cell can become cancerous in the body, like brain cells, blood cells, any part of the cells, any tissue can become cancerous. So once cancer start growing, it will spread. It will grow from that place to distant places through blood vessels and lymphatics. This is how we stage the disease. Whenever the cancer is at that site alone, it will be early stage. When it is like local regional spread, we will say that is it will multiply and it will be keep on growing at that site alone. After some time, it will disseminate and go into blood vessels to deposit in other places and become distant metastasis. This is a stage. Whenever it is in the local early stage, it is at that stage site only. Then stage 2, it is loco-regional spread. Stage 3, loco-regional with some mets in nearby. And stage 4 is distant metastasis to brain, lung, everywhere. So the cancer journey will be like this. So some cancers are preventable, not all cancers, because we don't have cause for all cancers. And some cancers can be diagnosed using screening technologies. Many screening procedures are there to detect cancer, but in our country, we are very much in back and we are not utilizing them properly. And then comes the diagnosis, where once it starts multiplying, we have to diagnose at that stage. Then after diagnosis, the treatment part, it can be either surgery, chemotherapy, radiotherapy, like that, or a mixture of everything. Then if they come in the early stage, they will be treated completely and they will become a survivor. If they come at late stage, it will be very difficult to treat them. And even if we spend, the survival will be very much minimal. So let's see our Indian scenario. Okay. So in India, we see in hospitals, we see cases only at late stage, the distant spread stage only, or local regional spread. What might be the causes, do you think, at your level? Like why they're not coming at early stage? Can anyone represent? Why we are missing cases at early stage and they are reporting to us only late stage? What might be the causes? What they think and what we lack?
Unawareness, ma'am.
Unawareness. Actually, previously there were unawareness, but due to the social media and now the awareness level have improved a little bit, but still
no symptoms.
Yes?
No symptoms.
No symptoms. For some cancers, there are no symptoms. For most of the cancers, some symptoms will be there, and symptoms at late stage only. For it will be there in some cancers. Next, anything? So we have many barriers psychologically. Whenever they think something is growing, like if they go to doctor, they'll tell abnormal, they'll tell cancer, they'll postpone. Our ladies used to postpone. They don't want to have economic backup in family. They don't want their husband or father or brother to spend for themselves. And they have to keep money for their son's marriage. Like plenty of reasons. And cultural, like they won't attend cultural functions. Social taboo, they think they'll be dignified, like they'll not attend functions, they'll be in the home itself, they'll be kept separate. Like that, many barriers are there, and breaking each barrier is very difficult to spread the awareness and tell them like it is easily curable whenever detected early. And the social media in another part, many dramas are picturizing like any cancer patient will die. Have you seen any film like showing cancer patient living alive? Have you seen? It's not like that. The social media also many time they propagate like that. So the main reasons for late diagnosis is lack of knowledge and misconception of cancer and unawareness by paramedical staff itself, and lack of organized screening programs. We don't have any structured screening programs. In Western world, we have a structured protocoled programs due to insurance covering the screening procedures. In our country, no insurance will cover these screening procedures. That is one major drawback. And lack of healthcare facilities in rural area and proper funding for oncology like cancer screening is not streamlined yet. So statistics, coming to the statistics, the top 5 cancers in men and women are like this. In men, it is lip, oral cavity, first place, and second comes to the lung. Then the stomach, colorectum, and esophagus all coming under GIT. So for this lip, oral cavity, and lung, what is the most important cause, do you think? Anyone?
Due to smoking and alcohol.
Yeah, smoking. Smoking is the main thing. It is the tobacco products. Either it is with smoke or smokeless products. In women, it is breast, cervix, the first and second, and ovary, oral cavity, colorectal in series. So according to the Globocon, is the major statistics what in our world, and it is maintained by IARC, International Agency for Research on Cancer, and the last data was shown in 2020. According to this, in India, the cases in 2020 were first breast, second lip and oral cavity, and third cervix, fourth lung, and fifth colorectum. As I put whole population, male and female together. So in this, breast almost 13% and cervix 9.4%, which almost comprises 22% only females. So the females are getting mostly affected by cancer, and almost 60% of the cancer patient will be female. So is cancer curable? See, like this, we have many treatment and many cancers can be cured. Like choriocarcinoma can be cured 70 to 80% if detected at early stage, and in non-Hodgkin's lymphoma, it can be cured like 60% completely. It can be cured, and ovary, if it is detected early, it is curable, but most of them present at late stage. Colon and rectum also nowadays, when they present at early stage, they are completely cured. Breast, almost in early stage, 70 to 80% they are completely cured. So the putting broadly, the signs and symptoms when you should visit doctor is whenever you have a change in bladder bowel habits, a sore that doesn't heal, unexplained weight loss, thickening or lump in the breast or any other part of the body, indigestion, obvious change. If you have a mole, if you have any itching over that, you have to report to your doctor immediately. If you have a continuous cough or hoarseness of voice suddenly, you have to report to your doctor. So broadly, the treatment options available for cancer is surgery, chemotherapy, radiotherapy, hormone therapy, and now the evolving is targeted therapy and immunotherapy and genetic therapy. So what has changed in cancer treatment is better screening techniques we have, increased awareness, medical research is improved, new technologies have come in treatment options, and surgical techniques, new techniques, and we have till robotic surgeries we have developed, new targeted therapies have come. So I will broadly tell about head and neck cancer, lung, breast and cervical cancer here. Yeah, anyone? So head and neck cancer comprises of the cancer occurring in the oral cavity, adjacent parts like that. So it is the most commonest cancer in India, and it is curable 50% of the time when it is detected early. Nose, mouth, lips, gums, everywhere, the adjacent area, adjacent side, whole thing, and neck. So the main causes smoking or smokeless tobacco products. Either way, both are harmful. And now there is the incidence of using these products are increasing at a drastic level. And the age they start, like in teenage, in the most, they are getting addicted at school time itself. Teenage, in the sense, 8th standard, 9th standard students are getting addicted. They are targeted, and when they get addicted, it's a prolonged period when we detect, and they'll get cancer at early stage itself. So see, there are 4,000 toxic chemicals in a cigarette. Out of them, 60 are proven to be carcinogenic. Okay, like these are the various chemicals what we know, but there are plenty of smoke products. Like it should be research, great research on that. Butane, cadmium, stearic acid, hexamine, like that. Everything, these things are proven that they produce mutations in the genetic cell level and produce cancer. So see the hidden danger. So all these comprises, when we inhale, we are inhaling so many chemicals inside, targeting the lungs, and knowing this, doing smoking is very harmful, and it is very difficult to quit smoking once you start smoking. So the next, the smokeless products. It is of numerous names like Hans, Panparak, whatever it is, like many thousands of products are there. Under the tongue, side of the tongue, gums, what area in the tongue, everywhere they will keep these products. See, this form of betel nut is also dangerous. And nowadays we could see more of oral cancer in Tanjavur district and all due to the betel nut chewing habit in females. The incidence is rising there. So then comes the passive smoking in the house when the kids are nearby and so the parents smoke, they are getting affected with asthma, and in long standing there may be effect in them. In prolonged effect they may have cancer also like that. It produces numerous, like equally they are getting affected with this passive smoking. So see the warning, even though they put the danger symbol, everything, they will have this. And in India, it nearly kills like 2,500 Indians per day, this tobacco. It is not only with by cancer, by stroke, by heart attack. It can produce all sort of problems in the body and kills nearly 2,500 Indians. The statistics date back almost like 7 to 8 years back. Nowadays, it might have increased. Then comes the new danger. What is this? What is this?
Pollution.
Air pollution. So it's there everywhere in India at various levels. So it's not seen, but when we feel it, we could feel, and it is going to become a huge danger in near future, producing cancer, lung cancer. Then comes the oral cancer. So the main warning signs are any persistent white or red patches, painless, and repeated treatment also, it's not healing. You have to consult a doctor for biopsy. And any persistent lump swelling in the neck or any in the tongue, anyway, like head and neck, oral cavity, you have to see a doctor. Any voice change, like that, tobacco is the main thing. See some of the photos of our patients. This is carcinoma of lip. See the lip. With this lip itself, you smoke. You won't stop smoking also. Even after treatment also, they'll go back. After treatment for 3 months, 2 months, they'll be free. Then again, they will revert to the initial stage itself. So stopping smoking is not an easy job. It should be a multi-level approach with family counseling properly, and family should support, and the patient should take in depth that they should quit smoking. So see, floor of the mouth, under surface tongue, mouth, near tooth, gingiva. See the cancer. See the cancer growth. And after treatment, we have put a flap and see how it is. Tongue cancer. After treatment, this is. So next comes the lung cancer. The main warning symptoms being chronic cough. We think which they would have thought like asthma is there, but it is not getting controlled with the inhalers and all. You have to go and rule out cancer. Coughing out of blood, changes in voice, chest pain, repeated chest pain, shortness of breath. Like that, any symptoms is there, they have to rule out cancer is there or not. Smoking is the main thing. See how smoking is affecting organs from head to foot. It will not spare any organ, like cancer of the nose, mouth, and chronic bronchitis, infertility, gangrene of the foot. Somebody is disturbing, madam. Stroke. Can you mute yourself? Stroke, defective vision. So nothing is spared. Each and every organ is getting affected with this smoking. See how the lung cancer with smoking, the charred lung, and this is the normal lung. So if you have any long-standing cough or shortness of breath, anybody is having, or blood in the sputum. In India, tuberculosis is the main problem what we have. We have to rule out tuberculosis first, and then we have to go and check for any symptoms of malignancy. So please quit smoking. So these products should be banned. Next comes the colorectal cancer. The main warning symptom being blood in the stool, any feeling of repeated bloated sensation, repeated diarrhea or constipations. If you have to report a doctor immediately. And any bowel habits repeatedly, if it is getting altered, it should be addressed properly. So the risk factors being any family history is there, definitely the children should get screened with colonoscopy, history of IBS, inflammatory bowel disease, familial polyposis, any previous history of breast or other cancer like ovarian cancer, they have a tendency to develop colorectal cancer also. The high consumption of red meat and low fat diet is also an important factor for this. So please never use alcohol. And now the product what we see across the city roads, the barbecue items have come in. So this is, we think it as protein, but once the protein is repeatedly heated with directly, after certain temperature, the protein becomes toxins. It will be cooked initially, then the proteins become toxins, which will enter the gut and it will produce carcinogenic effect. So it is also harmful. When beyond a limit, it is definitely dangerous, and this is not the way to cook and eat. So these are the thing. And coming to breast cancer, the first cancer, the important thing, and we alarmingly see the increase in the number of breast cancer. So here there is no etiology. This is the cause, like that we can't tell in breast cancer, but there are some risk factors which are modifiable and some cannot be modified. Some factors which are non-modifiable being age. As aging occurs, a female has the risk of developing cancer increases, and like BP, sugar only. And now we could see many young girls attaining menarche at the age of 9 years, like that. Can you tell me the cause, like what you think about it, professors, teachers? So before and all, our age at menarche is 12 to 13 years. Now what age you are seeing? Which standard girls? Anyone?
Maybe due to LH and FSH hormone imbalance.
Anyone? So now we could see many like the previous childhood activities or regress. The lifestyle is totally changed. Increase in the like physical activities totally decreased. Obesity has increased. The time with the gatherers is increased. Then the food habits. The lifestyle includes food habits, exercise mainly. Both are altered at all levels. And after COVID, it is even more worse. So due to this, there is increase in the fat consumption, and with the fat metabolism, there is be increase in the estrogen, like that. So hormonal imbalance occurs and they are getting menarche earlier. And menopause also, due to obesity and other risk factors like diabetes, they are getting menopause around after 55 years also. For Indian standard, it is around 50 to 55 years the woman should get menopause. But now we are seeing many women after 55 years also, they are getting periods. So the prolonged period of having a menstrual cycle will have a wear and tear effect on the breast, endometrium, everything. And these women are more prone for getting breast cancer as well as endometrial cancer. And now women are postponing their marriage due to studies and occupation, like that, for their career improvement. But the fertile age is like 25 to 30 years. So the best is to complete the family before 30 or around 30 years. And when they postpone after 35 years, they need to approach a doctor, consultant, and they have to have hormones for support, hormonal support. So these things increase the risk for breast cancer. So then comes the breastfeeding. So even government is giving so many chances, like 6 months, 1 year maternity leave for exclusively breastfeeding and taking care of the kid. Many women are telling no feeds, so we can't feed, like that. But it is very essential to feed the baby exclusively till 6 months, and will have definitely a protection for breast cancer. But we can't tell that whoever feeds, they'll not get breast cancer. It's not like that, but definitely it will have a protection against it. And some genetic factors, breast cancer run in families. 10% when a mother is having breast cancer, 5 to 10% the girl will have increased chance of getting breast cancer, and she should get regularly screened earlier than others. Next comes breast examination. So what we can do for ourselves is the self breast examination. It is like the opportunity of a woman to check herself, and she should be familiar with her breast. It should be started from the college life itself. So 19 years, around 19 to 20 years, they can start self-examination, and it should be done after periods, like 7th day, like that, once in a month. The breast should be checked, and underarm area, axilla should be checked. It should be monthly once, and it should not be done repeatedly. And anything abnormal noted should be immediately reported to doctor. Then comes the clinical breast examination, which should be performed by a trained doctor or a trained nurse. And from 40 years, better to have a consultation and to undergo screening. So the best time to check ourselves is while showering. So whenever like monthly once after periods, we have to check ourselves to see the contour of the breast, any changes, nipple level, and color of the skin. Like we have to watch with the flat surface of the palm, and not should not pinpoint like this. We have to, with the palmar surface, we have to gently see all around the breast tissue to check for any lump or any discomfort. We have to check in lying down position also and see for any nipple discharge. So if you note any lump or thickening, discharge or bleeding from the nipple, or any changes in the contour of the breast, nipple inversion, any change in color of the areola, the tissue around the area around the nipple, or redness or pitting of the skin over the breast tissue, you have to note your doctor. So see, we can compare like this. When cancer is there underneath, there might be changes like this: thick mass, inundation, the skin will go inside, eroded skin, lump, redness, nipple discharge. Like this, we'll have many changes. So actually, we should not come till this stage. It can be detected very early. If it is like this, they are at almost in stage 3. Next comes the gold standard screening technique. What we have is the full field digital mammogram. It is the X-ray of the breast. As X-ray of lung, it is the X-ray of the breast. For Indian scenario, we advise once in 2 years from 40 years of age. But ideally, it should be an annual mammogram, yearly once after 40 years to 65 years. And it is the gold standard technique. We have detected nearly 4 millimeter, 5 millimeter lesions, which can't be palpated by hand. So like it can detect the lesion 2 years before what we can feel in hand. Doctors can feel in hand 2 years ahead, it can detect. See, this is the mammogram unit and the lesion detected. And in India, a woman will have dense breast. So it will be a test first, mammogram will be done, then ultrasound breast will be done. Both will be read by the radiologist, and the final report will be given. So this is how staging is done in breast cancer. Every cancer will be staged into 4 stages. In breast, it is like this. The stage 1, that one area alone. The stage 2 with the nearby axilla, stage 3 more than that, and stage 4 distant metastasis. At this stage, whenever a patient comes in 1 or 2 stage, 95 to 99% it can be cured completely. Then comes the cervical cancer, the preventable cancer, what we have, and we have to work together for its elimination. So the main cause, we have a cause for this cancer, hence it is preventable. 90% of cervical cancer is caused by human papilloma virus, a viral etiology. This virus is normally in all sexual women, it will be there and it will be cleared off with their immunity. So in immunocompromised or STD women, it will be, they have more chance to get this cervical cancer. So from the infection of this human papilloma virus to become cancerous, it will take nearly 15 to 20 years. So it's a huge gap in which this it will be going a pre-cancerous stage. It is the before coming to cancer. In this pre-cancerous stage, we have many screening technologies to detect at the stage, and it can be cured completely. So the patient will not become to cancer stage. So if it becomes cancerous, they'll have more symptoms like excessive white discharge with foul smelling, repeated urinary tract infection, post-sex bleeding, non-healing ulcers, and irregular intermenstrual bleeding if it is there. These patients should report immediately to the doctor to see whether any cervical changes is there. Here are some screening tests. What we have is the Pap smear. It is a simple OPD procedure, 2 minutes procedure, where the cervical cells are scraped and sent to cytology. The report will be available in a day. Actually, it is a simple 2 minutes procedure, and once explained to the patient, they will easily accept for it, and it will detect the lesion in pre-cancer itself. It will not go to the cancer stage itself. So this should be started from 25 years of age. In India, we tell it is around from 30 years, they should get started screening, and once in 3 to 5 years, they should get repeated. Whatever symptoms I told before, those patients should report immediately to the doctor. This screening test, whatever we are telling, like mammogram, Pap smear, these things is for normal, healthy women population. So after marriage, whenever they cross 25 to 30 years, they have to take a Pap smear once in 5 years, and after 40 years, they should start a mammogram, and Pap smear repeat once in 5 years till 65 years. Okay. So if the Pap smear is becoming abnormal, then the patient will be advised regarding colposcopy. That is magnification of cervix and checking for any abnormal area for biopsy will be done. So we will stain the cervix to see the abnormal area. From that area, we have to take the punch biopsy. The staining solution used here is 3 to 5% acetic acid and Lugol's iodine solution. So this is how the report will be. See how it is, like we have stained with the solution like this, and the astrocyte area, the white area, what you see is the abnormal area. First acetic acid, then Lugol's iodine. So from the white area, we have to take the biopsy. For this patient, it came a precancerous lesion was diagnosed. She had an associated bleeding disorder like dysfunctional uterine bleeding. So she went hysterectomy. So whenever a patient is detected in a precancerous stage, she can be treated effectively with these OP procedures, which are short, simple procedures like cryotherapy and thermoablation, which doesn't need any anesthesia. Only it is a OP procedure, and it is easily manageable. 3 to 5 minutes is the procedure. Cryotherapy is using liquid nitrous, and it is a 3 minutes procedure. The patient will be comfortable, and the outer layer, the abnormal area will shed, and a new layer will form. Thermoablation is a heating technology. The other thing being leads and bone biopsy needs anesthesia, but the area will be removed for sent for biopsy, and they'll get cured completely. So the preventing factors we can follow is avoid early marriages, avoid multiple partners, use of condom will protect against it, good nutrition, smoking, regular exercise, and good checkup, regular checkup and screening should be done. Once cervical cancer is diagnosed, the treatment option being lap radical hysterectomy and external beam radiotherapy. So for this human papilloma virus, we have a vaccine. Gardasil and Cervarix, 2 brands are available, and recently launched, last month they launched one, like with Serum Institute of India has launched a Covax. It's a vaccine which is low cost, 200 rupees it has come, and mostly government will adopt, and all will have. These vaccines should be given to girls at 9 to 14 years of age. Between 9 to 14 years, it is given as 2 doses, 0 and 6 months. After 15 years, from 15 years, she should get 3 doses. Till 40 years, we are planning to, we are giving the vaccine. And Now it is available as optional vaccine. In the immunization chart, it will be as optional vaccine. The parents can decide and take the vaccine. Soon the government will take up this and it will be implemented. So general preventive factors, what we can tell is eat a good, healthy, nutritious diet. Eat properly, like mixed vegetables should be there. You can't keep on eating same vegetable. It should be a mixed thing so that all nutrition is covered and antioxidants should be taken. Then fruits, variety of fruits. Each day one fruit should be taken. Nuts are much important for protection. Then exercise. Coming to exercise, I don't know, nearly in this 100 participants, I think like nearly 5% will be having this exercise attitude. Only wherever I go, I ask them to lift their hand. I see in 100, 2 to 3. That is how we are taking up the exercise in our mind. So it's not like that for all age groups. It's not like school girls, for everyone, exercise is important because the lifestyle is totally changed now. It is like 40 minutes per day is an ideal time, and 5 hours per week you can take it as like that. 5 hours per week you have to definitely work out. Like if I ask, they'll tell I walk 1 kilometer for work, like this. It is not at all exercise. I climb 2 stairs in my office. It is not at all exercise. You have to spare some time for yourself. That is exercise, and burn out your calories. Daily 40 minutes, weekly 6 days, definitely you have to work out. 1 day you can spare, but 5 hours per week you have to have exercise done, which will have a good effect. You can see the effect only after 6 months. It should become a habit. Then only that habit will show the effect. It is not like 2 weeks I started, then I left it, then you won't have the effect. It is like whenever it becomes a habit, definitely you will see the effect. I'm lean, I will not do exercise. It's not like that. For everyone at whatever age, some physical activity in the form of exercise is essential. And then comes to sleep. So ideally, we should have 6 to 8 hours of good sleep for prevention of many things like BP, sugar, cancer, everything also. So nowadays, all are going to bed with gadgets only. So the bedtime is not equal to sleep time. So from the bedtime, we have to subtract the gadgets time. Like that, it's becoming. So during the night, without light, if they see the monitor, phone monitor, there are some radiations which will affect the sleep, mood, everything. So definitely, whenever you go to bed, don't go with your gadgets. Please, please, please. So it will definitely have sleep disturbances. Have a good sleep. Don't see your mobiles 10 to 15 minutes before sleep. Switch it, keep it aside, and have a good sound sleep. I think you all will agree for this because I could not interact in between. Can anyone in this tell that I am going to bed without gadgets? I will go and sleep. Anyone? In the audience? Then comes the stress. Now, ruling out other factors, what we have found is stress is becoming one of the most important factors for many problems. Whatever we tell heart attack, it is all different. For minor hormonal problem, nowadays we are telling that it's PCOD, like that. So for hormonal problems also, we feel like stress is having an associated factor. For infertility, it's coming up to cancer. So I can't tell be relaxed at whatever way you are. It's not like that. Our way of working pattern, whoever it is, housewife, everyone will have stress at some level. But see to that stress should not affect your health. So there should be a limit. Okay, stress, we are stressed. We have to meditate. We have to do yoga. We have to spare some time for ourselves to relax. Like whatever you like, hear music, spare some time for yourself and get relaxed. So keep your stress at minimum level. So this is regarding cancer awareness. So we'll move on to the subtopic in this, like cancer registry in India. So madam, I'll take up the question at last only, no madam? If any interaction is needed now, anyone, 1 or 2 can ask questions at this point of time in cancer awareness.
So let us make it an interactive session. Any participant is required any clarification, kindly now you can unmute, speak. Or you can put in chat box also your doubts. Any clarification is required, dear participants?
So we'll move on to cancer registry in India, madam.
Yeah, ma'am.
Anyone? I'll start this one. So, what is a cancer registry? A cancer registry is an information system designed for the collection of data and management of data on persons with cancer. It plays a critical role in cancer surveillance, and it also serves as a foundation for cancer research and for planning and evaluating cancer prevention and cancer control interventions. For example, we can see like the COVID is the best example. Like we have all the data from first day of COVID. Like during the first wave, second wave, everywhere we had data and properly we guided vaccination, how much data we have, how many of them are having single dose, second dose, everything we had. So everything with the data only they managed. So in this aspect for cancer also, it is very important. So how many of them are getting colorectal cancer? Is Chennai is witnessing more amount of breast cancer? Is cervical cancer is declining? How we can tell? Only with these numbers. So cancer registry, once the data are collected, it is stored and disseminated, analyzed properly, and then it is used for research and application. So the purpose of cancer registry is to establish and maintain an incidence reporting system, to be an informational resource for the investigation of cancer and its causes, to provide information for public health officials, and to plan and evaluate for prevention and cancer control programs. Basically, it is divided into three, and the one more type is the special registries on specific cancer. The basic types are population-based cancer registries and hospital-based cancer registries. So the who takes the thing, cancer registers are the people who collect and report the cancer data to the institute. So coming to population-based cancer registry, it records all cases in a defined population. An emphasis on use of the data for epidemiology. It determines cancer patterns among various population or subpopulation. It monitors the cancer trends over time. It guides in planning, evaluation of cancer control efforts. It also helps to prioritize the health resource for which cancer we can allocate, for which cancer we can allocate fund for screening, and to advance in the clinical, epidemiological, and health services. The hospital-based cancer registry is mainly to maintain data in a hospital and to focus on improving the hospital facilities and administrative process, clinical research, and professional education. The main thing in this data is the confidentiality. What we have to think more about is there are many regulation policies and laws such that no patient data or identification should be given to the research, or anyone handling should never know which patient is having what cancer, like that. Everything should be masked. So it is the de-identified information what we are providing for any research or anything, whatever it is, all complete data regarding the identification of the patient is masked. There are many protections for them, because it will be a total unethical if we release everything. So there can be a variety of research using these registries. So like identifying the emerging cancer trends and investigating health disparities between each and every area, like rural, urban, and which cancer patient is surviving more, what and all treatment is effective, and how it is getting affected, how the patients are after 5 years they become survivor. So how many patients are surviving with that cancer, whether the second chance of cancer is coming. Many patients live longer, so they have the second chance of getting cancer and they'll come with other cancers. So it is called the second primary, what we call it as second primary. So what are the chances the patient will get recurrence of the same cancer or a second primary like that? Nowadays, we could see many patients with double primary, like one side breast cancer and another endometrium at the same time they are coming. So these pattern of things, only when we have how many patients are having dual cancer like that, we can have a research modality for them. So our cancer registry in India is divided into 6 geographic zones. Delhi and Patiala with the north, and south comprises full of Hyderabad, Kollam, including the Chennai, east with Calcutta, and west Aurangabad, Osmanabad, everything, and central Wardha, Bhopal, and Nagpur, and northeast Manipur and Mizoram, these things. So it is divided into 6 geographical zones from where we get the data. So this is the one. There are 36 population-based cancer registry, 2 in north, 5 in south, 1 in east, 6 in west, 3 in central, and 11 in northeast. And 236 hospital-based cancer registry from the 6 zones, 43 registries in north, 55 from south, 12 in the east, 10 in west, 16 in central, and 12 in northeast. Actually, Chennai have a good cancer registry, better than others, because we started collecting initially from prolonged stage. Our cancer institute is having the data, everything, and we have good valued data and standard data. So from the data, what we have, in 2020, the NCRP has consolidated data and they have analyzed. And they have shown the projected incidence to 2025. See, totally putting all sides together, there is a 25,000 like increased, 2.5 lakhs increased. The tobacco-related cancer has increased this much, and every cancer, like almost it is 50,000 to 60,000 patient has increased in all cancers. Putting together, 15,69,793 cancers patient in 2025. So this is how they have projected, and it is a mere number, and we can imagine there might be much more number than this, as we can see many breast cancer patients, young patients nowadays, colon cancer is increasing. We could see the increasing trend in many pattern of cancers. So we'll see some of the scary statistics from these data. The Aizawl district from Mizoram had the highest age incidence rate and mortality. 1 of every 4 males in this district have the chance of developing cancer in the life period of 0 to 74 years. 1 in 4 is very dangerous, and 1 in 4 females in Papampure district, they'll have the chance of developing cancer in the age group of 0 to 74 years. Putting together, as such in India, 1 in 68 males have a lifetime risk of developing lung cancer, 1 in 29 for developing breast cancer. So, but in this is 1 in 29 in full India. But in Chennai and Bombay, like that urban areas, it is even more worse. 1 in 22 females have the chance of getting breast cancer in their lifetime. Everything consolidated, 1 in 9 Indian will develop cancer during their lifetime. 1 in 9 is not a big number, so it can be anyone. It can't be pointed out like you will not get cancer, you will get cancer. It is not like that. It's a very scary statistics, and almost 1/3 of the cancer is caused only due to tobacco. This tobacco-related cancer is the highest contributing factor in India. So, and approximately 70% of, when we analyze, it is like 70% of cancers can be potentially prevented. The cervical cancer can be totally prevented and eliminated. This tobacco-related head and neck, oral cavity, lung cancer can be totally prevented. So for the cervical cancer, WHO recently, before COVID, they started the concept of elimination of cervical cancer with this targets of targeting vaccination, early screening technologies, and treatment technologies. And by 2035, we have 2035, we have the target of nearly 90% children should be vaccinated. Like that, we have a target. So the main challenges in India with this cancer registry it is not a notifiable disease. So any disease, if it is notified only, it will be immediately taken up by the data. So COVID and all, we are still notifying COVID. Daily we are reporting like how many COVID cases in each thing to the district. But cancer is still not a notifiable disease. Hence, many area they missed out. So from the death certificate, we can't get all the data. From the death certificate, only partially we can get the data, as our data system and the workup filing, everything is lagging many things. So the mortality registration, that is death certification, has several gaps. Otherwise, we can get from the death data. It is very difficult, and unless it becomes a notifiable and properly documented certificate from the death certificate, data can be sure and complete value data can be taken. And it is a passive notification, like cancer, that registrar will be coming to hospital, we will give data, like that it is going on. And in many health record, there will be, they will not write the proper cause. It can be cardiac, they'll write simply, and we can't get the cause of death properly. Unless we have a thing correctly, we will not have it properly with the registered number or coding. Even though we have international coding, everything, still we miss the proper cause of death for many deaths in India. So this is regarding the registry. So thank you for patient listening, and any doubt or any clarification you can ask me in this session.
Participants, let us have a 10 minutes interactive session, and then ma'am will proceed to the next part of the seminar. I could see some of the questions from the chat box, ma'am. Mr. Madhavan asked, what are the symptoms? Cancer symptoms.
Cancer symptoms. Like I have put on like general symptoms whenever it is there, like any mole itching, any lump in your any mass, any lump which is not healing, which is not reducing, suddenly it is growing, recurrent cough which is not treated with regular inhalers and all, thinking it is asthma, if you're getting treated and it is not subsiding. Then blood in the vomit, blood in the sputum, sudden loss of weight, loss of appetite, unable to eat properly, voice changes, any oral ulcers not healing, oral lesion not healing. So these are broadly can be told. Each organ will have some symptoms. So I have elaborated by some basic things. What we know is the colon, oral cavity, everything I have told. These are the generalized symptoms. You have to take it in mind.
Ma'am, there is a second question, ma'am. How to prevent breast cancer?
Breast cancer. So it is not having a cause or etiology. So it is not like cervical cancer. We can't tell it is it can be prevented. It is a preventable cancer, like that we can't tell. So it is, we can reduce the risk. I told some modifiable risk factors which can be changed. So it can be detected early with screening only. So screening is the dictum for breast cancer. Early detection is the key. For cervical cancer, we can tell elimination. For breast cancer, it is early detection. So at self-breast examination, clinical breast examination, screening started at correct age will be the prime important factors for, it's not prevention, we can detect early.
Okay.
Like diet, you can diet definitely will have an effect. Diet, lifestyle effect, lifestyle modification will definitely have a reduction of 15 to 20% of these risk factors, like good diet with proper nutrition of vegetables, nuts, fruits, low fat calorie intake, like that. If you take, definitely it will have help. Exercise, these things should be adopted properly.
Another question, ma'am. Does cavities develop oral cancer?
It's not like cavities. Cavities won't develop. Any ulcer or pain, constant pain, any ulcer, after ulcer, they will tell. But some ulcer, after ulcer with nutrition, or it will subside in a 3 days, 4 days, 5 days, like that. If any ulcer or any thing not healing for more than 2 weeks, like that at all, you have to definitely report to a doctor and evaluate on it.
Same question, ma'am. How to prevent from this cancer you have answered already. Will PCOD problem leads to ovary cancer?
PCOD problem will not lead on directly to ovary cancer. It will have other effects, obesity, and it can have effect on endometrium. It will have the repeated endometrial building. Later, it will have more chance for getting endometrial, uterine cancer, breast cancer, because they'll go for treatment for infertility, like that. So they have more chance of getting endometrial breast, like that.
There is another question by our participant, Basma. One of my relative is having cancer in the knee. Is there any chance of getting cancer due to sports activity? What is the cause of cancer in the knee?
Knee joint, madam?
Yeah, knee joint.
So knee joint, I don't know whether it is from bone or anything. Sports activities definitely will not lead on to any cancer. So it is like, if it is bone cancer, there is no cause for bone cancer also. Some radiation, mild effect may be there, but we can't tell this is the reason for bone cancer, like that. But sports activities definitely will not increase. Definitely it will not have the etiology for cancer, like that.
Any questions from the audience?
Is diabetic increase the chance of cancer? Definitely diabetic, uncontrolled diabetic. If diabetes is controlled properly, definitely it will not cause any harm. But uncontrolled diabetes is definitely going to cause many problems with breast, colon, everything, kidney, renal, actually it will have blood pressure, like that. It will be a complex thing, and it has mild chance of increasing cancer. Next.
That's all in the chat box from questions.
You mean to say PCOD problem leads to breast cancer? PCOD, as per, it won't cause, but the repeated hormones what they are taking and infertility workup later, like that, they may have a chance of getting endometrial cancer. They have a mild risk of increased breast cancer also.
What is a drug to be used to control the cancer?
It is not like we don't have, if I have the tablet, I will give to everyone to prevent it. I'm a preventive oncologist. There is no as such drug. There is a vaccine. Now, what I told, vaccine, no, you have to understand the concept of vaccine for prevention. Food items to follow. So I told it's a mixture of good vegetables, mixture of, it should be mixed. There should be not a constant thing, fruits, nuts, low fat diet, dairy products also, you minimum after some age, burn your calories. Whatever you eat, try to burn with doing exercise.
Ma'am, you mean to say PCOD problem leads to breast cancer or uterus cancer?
No, I told you it's not like as per it is the direct cause. I can't tell. It is a sequence of events which will be going, like they'll be going for treatment with infertility, like that, and they'll have a repeated uterine abnormal bleeding. So which will produce to endometrial hyperplasia, what will tell. Endometrial hyperplasia, which is a preponing factor for endometrial cancer, like that it goes. So there is a chance and risk for developing uterine cancer.
Any questions from the audience? If there are no questions, I think we can proceed to the next session now.
Okay, okay, ma'am. So shall I start, madam?
Yeah, ma'am. Yes, ma'am.
So we'll move on to the second part. So in this, we will see overview of data in oncology and some ongoing projects. So why do you think data is needed for oncocare in India? Can anyone? Can anyone represent? Students? So this is how the trend and disparities. There is a huge disparity of cancer healthcare in India. India with a huge population of 1.3 billion and it's growing exponentially. So we have many interesting and challenging healthcare problems in India. Cancer as such, it is a heterogenic disease. It can be, it is differing from state to state. The pattern differs from each state, each rural area, and within state there will be difference between urban and thing. So there has a much heterogeneity. So whatever data we have, the available data, access to healthcare, affordability, everything are poor in some area or somewhere it is rich like that they will get. So most of the population are not accessible to proper healthcare. And when we come to insurance as such, it is almost only 5% is covered with insurance. 95% of the population, Indian population, is zero health insurance. So there is so much inequity. In Western world, we can see almost all are insured, and every data, whatever they are doing, screening, everything will be documented, and correct age screening, everything will be done. So data is needed for providing equitable cancer care in India. This is like equity of care should be stabilized and proper data will be available then only. So for it's either way, and a rapid rewind, like this is how the cancer incidence projected from the data 2020 to 25. So such a huge number we are going to see in 2025. Every cancer incident, every cancer number is increased. So how we are going to cope up with these increased numbers and what we have to plan as such. So for that, we need a data. This is the projected incidence calculated with various statistical analysis, like tobacco cancer from 37 to 40 to 4,27,000 and gastrointestinal 2,73 to 3,10,000 and cervical cancer, everything is getting increased. Breast is also 2,05,000 to 2,32,000, it has increased. So the statistics value as it increases, we have to be prepared for that. And if we know the numbers, by screening, we can detect early and we can definitely have some changes in the numbers. If we screen the population, vaccinate the population, we can see a change in the numbers. So as told previously, see how the risk numbers is there. In that Mizoram district, Aizawl, it is 1 in 4 in male and female lifetime risk. Like if there are 4 women or 4 men in area, among them one will be getting any type of cancer like that. So see Chennai, it is like 1 in 8 in men, 1 in 7 in women. So see the risk. If 7 women are there, one of them will have a lifetime risk. So we can't tell who is that and how we are going to plan the screening for her. So like this, each district, it is quoted like this. So it is definitely a scary numbers, and we have to analyze ourselves how to overcome this, any method to analyze this, prevent this with screening, vaccination. We have to come to a proper methodology. So, and what patients as such, initially I told it is, we see many patients with metastasis only. Lung cancer and all, almost 44 to 47% of female are coming in late stage only, after spread only, because initially this cancer will not produce much symptom also. So like this, they have come with so many patients with huge symptoms. They will be difficult to treat. They'll be dying. Many young women I could see with lung cancer nowadays. Stomach cancer also almost 50-50. They'll come in early stage and like early stage in the sense loco-regional spread, and 50% most of them will come in distant metastasis. Breast, it is like they'll come with a loco-regional spread only. 50 to 60% of the women will come with a big lump. They'll not come at the early stage. After knowing the symptom, they'll wait for nearly 3 months to 6 months to approach a doctor. And after approaching a doctor also, they will not start a treatment. They'll go through a circle of thing, like they'll have their own ideas, they'll discuss. So till doctor identification and treatment start, they'll give you a gap. In that time also, cancer will be spreading. So it will become next stage. When the treatment is getting started, it will go to the next stage itself. Like that, we are seeing patients. And so the postponement from the date of what they feel and the treatment itself, it's due to the patient themselves. So this time period at least should cut. Whenever they feel any discomfort or any changes, they should report immediately to doctors. Then cervical cancer, there are many screening vaccine. Even though we are getting many cases with local spread, only 60% of the patient will be coming with local spread. They won't discuss regarding this white discharge with friends like that. They will not tell regarding the breast lump, white discharge. They will not discuss with their husband or any like relation, sister. At last, whenever they can't hide it, only it will be exposed. So with this backup knowledge, we are going to incorporate our data science knowledge so that how we can put our input so that we can prevent or screen or detect early stage or any treatment modalities we can change. We are going to see. So coming to data science, it incorporates various disciplines like data engineering, data preparation, data mining, predictive analytics, machine learning and data visualization, along with statistics, mathematics, and software programming. It is primarily done by skilled data scientists, although lower level data analysts also getting involved. In addition, nowadays we could see many of them include business intelligence professionals, analysts, data engineers, and other workers who don't have any proper analytical knowledge also, but they have a data science background. So it is an interdisciplinary field that extracts knowledge from various things, and putting together, we have to analyze, and we are going to create a methodology with the structured and unstructured data, whatever we are having. So in this, the correlative science data is the one which understands cancer biology and use this knowledge to improve cancer therapies and outcomes. Patient-reported data reduce the burden of cancer and treatment for patients and their carers. And the real-world data will improve cancer by demonstrating the value of cancer treatment. So these are the various data examples like the CRF supporting system, voice web media resources, and documents all come at clinical trial data. The electronic health record, billing activities, registries what we are maintaining, and patient generated data, and from the data gathered from other sources like mobile, everything will come under real world data. And the screening questionnaire, PRO, census, and variable diseases will come under patient reported data. And the data on biomarkers, IHC, fish studies, radiomics, pathological diagnosis, images will come under correlative science data. So putting data from all this, like clinical trial data, correlative data, real world data, we have to utilize B in the sense the patient, clinicians, correlative scientists, statisticians, clinical research associates, artificial intelligence researchers, health economists, policy makers, politicians, regulators, all will come into, they have to extract data from this and they have to utilize in a proper way for creating a methodology. So this data science platform should be utilized properly to solve the cancer together with all of us. So coming to big data, it is in the big data in healthcare is a term used to describe massive volumes of information created by the adoption of digital technologies that collect patients' records and help in managing hospital performances. Now, the current focus is not how big or how huge the data is. It is the how much granularity, how depth we have taken the record, and how smartly we are going to manage with the data we are going to see. So there are various 21 uses of big data in healthcare. So one of the best example I could see is COVID-19, from which we got many ideas how digitally healthcare can be improved and how much it can be utilized with the vaccination, everything. So can anyone from your point of view can explain how COVID-19 with the data analyst is utilized? Can anyone tell? Teachers? So from nobody? So from the utilization of health records, patient records, initial visit, from day one, we have the record of COVID-19 patients, how many of them in each hospital, how many days they stayed, and so many drugs we changed from initial. Everybody will know what and all drugs they changed initially. Everything were presented in the social media, trials, everything were displayed in the social media, and all could have the knowledge of COVID-19. It was like that. And vaccination, it was extensively covered, and India set an example, and with so much huge population, we could overcome that third wave. We are not worried about that third wave, which were in other countries. And when we got initial first dose, we were very much afraid. After seeing the thing, we were the first person to get vaccinated. After that, when everybody get vaccinated, we could see in the second wave, the vaccinated persons getting admitted for low time, and they didn't go for any failure, and the death rate was minimized. So COVID-19 is the best example for having the data. Still now, we are giving data like how many fever patients, how many COVID patients we are submitting to in hospitals. We are submitting the data to the collectors daily, and it is displayed each day the COVID number in Chennai and Tamil Nadu and India. We are getting the data. So with the numbers only we can monitor. If suddenly the number rises, we have to concentrate on that area. So the data is very much important. After COVID, it is a boomed thing that how much importance we have to think about maintaining the data in your hospital setup, population coverage, everything linked with the mobile number, Aadhaar number. So each and every patient can be tracked. As it was a notifiable disease, everything we have noted. So cancer, there is a huge lag of notification because of the previous factors I told, and we have to overcome that. I'll discuss later how to analyze it. The practice of telemedicine. See, after COVID, many of us, we started practicing telemedicine. Antenatal checkup, everything we did through online only, telemedicine. Now also we are treating patients from Bangladesh, Singapore, Sri Lanka. So they'll get opinion. If they want to have test done, they'll do the test there. They'll send the report. This through WhatsApp, we'll see the report. So it's like a travel time is cut, expenses are cut, and there are many positive factors using this data and digital healthcare, and we have improved a lot. Before 10 years, it was totally different. We can plan, strategic planning can be done, how to go to the next level. We can get prepared if any endemic or epidemic is coming. We can prepare, like oxygen levels, they started increasing the number of beds. So everything with numbers only they did. And due to this telemedicine, we are cutting short the hospital waiting time, and following up the patient after surgery also through telemedicine. If needed only, the patient is asked to come. And chemotherapy and all, we are scheduling online only. They can take the drugs there. With the investigation, we will see them online. Any parameters needed also through telemedicine, they will check the blood pressure, sugar, everything there, and they will show the report. We can track and control the diseases, and prescription online. So, so everything is digitalized. Actually, we are sitting with laptop daily. That is how it's going. So in this, how we are going to improve the cancer care from the cancer journey part in all levels, we have to utilize it properly. So let's see the 5 V's of big data in oncology. The huge volume which we have, because our population is huge, we are getting more number of cancer patients. So the volume is huge. Once we start collecting data, it will be very huge. Now itself it's huge. Properly, if it is collected, it will be very huge. It is from the diagnostic workup. It can be clinical, radiological, pathological. It can be from the treatment aspect, either systemic therapy, surgery, radiotherapy, or either combination of all the three things. The response to the treatment and its complication, and the velocity. They should be done with the increasingly high speed, and it should be digested fastly. And worldwide, the cancer rate is increasing, and due to the treatment, the patient also living longer. So they should be tracked till they live, till they survive. So how much year they are living, what complications they got, any chance of residual cancer, or any chance of recurrent cancer, or any chance of another malignancy coming on that individual. So everything should be tracked. Together with the technological advances and monitoring devices, an increasing number of data will have to be processed within the same time. Then comes the variety. It is having a huge variability of data types, which will give an important opportunities for us, and it will have challenges also. And the variability, that is the data capturing, varies from place and time. So each area will have different pattern. So it is a minimal data set, it's a prerequisite. So we should have a basic methodology for collecting the data. And the value is the setting up a data infrastructure to collect and interpret is worthwhile when it enables generation of data direct conclusion or measurements based on accurate data that can really lead to measurable improvements or impact in healthcare. So giving one example for that big data is the data set collected by the Cancer Genome Atlas, TCGA. It contains 2.5 petabytes of raw data, an amount that is equivalent to 2,500 times greater than the modern laptop storage in 2022, and requires specialized computers for storage and analysis. Between its initial release, the first release was in 2008. Till now, it has at least nearly more than 10,000 articles and 11,000 NIH grants cited according to the PubMed research. So for examples of different data, I'll see like for structured, that is a quantitative data that consists of numbers, values, relational data, or the CRF data and patient demographics. The unstructured data will consist of the audio, video sensors, descriptions, etc. DICOM images, physician notes, and narratives are this example. The semi-structured, which lies between the structured and unstructured, does not have a specific relation or tabular data model, but it includes the tags and markers that scale data into records and fields in a data set. These are the data repositories and clinical trials like that. The 5 basic types of data in cancer research are the molecular omics data, perturbation phenotypic data, molecular interaction data, imaging data, and textual data. The molecular omics data describe the abundance or status of molecules in cellular system and tissue samples. The most abundant type generated in cancer research is from the patient or the preclinical samples. It includes information from DNA mutation, protein abundance, which is the proteomics, transcript abundance, which is the transcriptomics, and metabolite abundance, which is the metabolomics. So these are the various molecular omics data in cancer research. The data type can be DNA mutation, chromatin accessibility, histone modification, DNA methylation, like that. So in DNA mutation, the whole exome or the whole genome is sequenced. So we'll have a good amount of molecular data from these patterns, like it can be proteomics or metabolomics. At that molecular level, with so much gene study has helped us in achieving many things in oncology. Let us see one by one. The perturbation phenotypic data is describing how cell phenotypes such as cell proliferation or the abundance of marker proteins are altered following suppression or amplification of gene levels or drug treatments. And the molecular interaction data describe the potential function of molecules through their interacting with diverse partners. It can be either DNA interaction or RNA interaction or protein-protein interaction and 3D chromosomal interaction. At various level interaction, the data can be extracted. And the image data and the molecular data are, there's no boundary as such. It is both include information of the other type, and for example, in data sets that containing imaging scans and on protein expression from a tumor sample. Then comes the clinical textual data, which are the data from the health records, histopathology images, and the radiology images. So from these data, whatever we get, we are categorizing them into three things. First is the projects that systematically generate the data. The main example is the TCGA generated transcriptomic, proteomic, genomic data for more than 10,000 cancer genomes and matched normal samples spanning 33 cancer types is a main example. And like that, many projects are compiled into repositories which presents the process data from the aforementioned projects, such as the genomic data commons, which host the TCGA data. And many repositories will be integrated into study like web application that is systematically integrating data with the diverse projects and provide interactive analysis modules. One of the main examples is the TIDE framework. You see, like this is the large scale project generating cancer genomic study, TCGA, which I explained, like it is more than 10,000 cancer genomes from 33 cancer type data is there. And ICGC, it is more than nearly 25,000 cancer genomes from 22 cancer types. Like this, we have many projects in which we have many data regarding the genomes, cell patterns, cell lines from different cancer types we have studied. So accordingly, they will take the data and match with the patient to get a proper therapy for them. We'll see that. Next comes the data repositories hosting cancer genomic data. These are the various things where many projects like TCGA, Target, Genie, and CPTAC all will be compiled into a repository GDC, in which 85,552 cases from 67 primary cancer sites, the data is incorporated, which will provide the cancer research community with a uniform repository that enables data sharing across genomic studies. Like that, many studies and repositories are there here. Then comes the web applications, which is the interactive model like C-Bioportal, in which 344 cancer omics data cohort from large scale project like TCGA and Genie, and many homogeneous data from individual studies, where the function is to interactive analysis and visualization models to find association from different data and clinical outcomes. So all the data will be incorporated, and with proper integrated analysis, the final outcome will be there. So it is basically integrated knowledge. The various data from the metabolomics, proteomics, genomics, whatever we are getting, we have to have integrated knowledge with the patient cohort data. We have to incorporate and then analyze. Finally, the clinical decision is combination of both the things. We have to study everything, and the novel treatment will be developed with the integrated knowledge of both the sides. So how we are going to utilize the big data in cancer research? The ongoing accumulation of records on a large number of patients reinforces the need for cancer research and clinical care to embrace computational solutions to effectively utilize all this information. It involves steps like data processing, storage, mining, analysis, and final applications, such as the identification of patient-specific oncogenic processes and markers. So, how artificial intelligence can be used in cancer research? It is the level of granularity is the very much important factor in it. How much granular the data is collected, the finer the molecular and clinical data, which will be providing a better stratification in oncology, as there is a huge heterogeneity in it. The convergence of artificial intelligence along with big data have facilitated the advanced cancer research, and the level of granularity will decide the variety of AI intelligence approaches, so that the more the depth, the greater the data we obtain, and the greater the AI is going to study on that. So we'll see some of the role of AI in cancer research. There are 6
Okay.
FDA-approved AI-based radiological devices with application in oncology are available for mammography and CT-based lesion at present. And 74 AI algorithms for digital pathology have received FDA clearance. And more than 300 AI-related clinical trials have been registered, and 7 randomized trials assessing AI in medicine have also been published. So, the big data and AI should complement each other, and both when coming together, it has the potential to fathom and overcome issues such as the reliability of biomarkers and genetic information, the potential disparities in patient population, and the limited understanding of side effects despite the growing promise of combination therapy and repurposing. And we need high performing computer system or supercomputer, which we call, are facilitating the deployment of pioneering AI applications in biomedicine innovative software and hardware solutions. So we'll see some of the examples through this AI, what and all we have achieved and what and all recently have been developed as I browsed. So the targeted therapy, what we use recently, attacking the specific gene has been an evaluation. It is done with the machine learning methods. So when we treat a patient with chemotherapy drugs from the beginning, after a period, they'll not respond to it. They'll stop responding. First, initially, if the tumor size is big and started shrinking, after some time, it won't shrink. It will be static. So we have to see the problem, why it is not done. So if you target, the main problem is if you are targeting one gene, the cancer cells can adapt and take another route. So it will go in another route and keep on growing. So we are targeting only one route. So as such, full gene, if it is targeted, it will be best to kill that cell proliferation. So it is not like one gene is a thing, the whole gene sequence should be targeted. So genome-wide casual gene regulatory networks constructed using newly developed machine learning tools will provide multiple targets. It is not a specific target. It is a multiple targets for novel therapeutic technologies. So it is all the genes at all levels will be targeted so that the proliferation will be stopped. It is one of the main important achievement by Zhang and her collaborators, and we are seeing many patients responding using these drugs, and the cells are not proliferating and they have good control. Even when they come at late stage, like stage 3, stage 4 colorectal, lung cancers and all, these target breast cancer and all, these targeted therapy is showing a very good effect, and the response is very good. The patient quality of life is improved, and we could see a marked change in their lifestyle. Then comes with all this data, the DNA sequencing, everything, the clinician will have a molecular tumor board. Some clinical clinicians will be compiled, and they use these sequencing method, and the patient genetic profile will be matched, and the new trial drugs, off-label drugs will be used on them. The end point is analyzed with the quality of life, how many years they are surviving after the treatment. After the analysis, the drug will be marketed with the name. So this is the process of thing when the drug is released in clinical trials. So one example is the new kinase inhibitor, in which the encoder develops the latent space, and a new novel targeted therapy of non-kinase inhibitors have been generated using this machine tool methods and artificial technology. So the another thing where we have used in diagnosing is, but we used to take multiple biopsies, but using artificial intelligence, a single site biopsy is enough, and the pathologist can confidently tell that there is no cancer, like that, using the input from artificial intelligence. The many data are trained, tuned, and tested and fed using convolutional neural network technologies. And when the pathologist is utilizing a single specimen biopsy image and comparing with these artificial image technologies, she can tell with one image there is no chance of cancer confidently. Otherwise, we have to take from multiple sites, and we have to proceed with multiple biopsy specimens, and the pathologist should read many slides. But now with one slide, with all this network technology, she could tell no cancer, we can go ahead. If there is cancer also, it will be showing the correct place to identify and where to get biopsy done. Like that, it's going on. And the main thing next what we have is a group with totally digital platform where we have an app to assess the risk for each and every individual, how much risk of developing cancer. If you go through this site, you can see whether you're having a high risk for breast cancer or low risk, medium risk for each and every 5 types, for especially 5 cancers. And they have good digital consultation. Everything is through online mode. Most of the thing will be handled online, and they have at next level only they will visit the patient like that. So most of the new technologies or digital healthcare only is popping up. And this is our trial. What we are planning and doing is the OncoShot, which help patients, caregivers, and oncologists identify clinical trials more efficiently and effectively in today's fast and changing landscape of cancer care. Or it leads for relevant clinical trials in minutes, whereas if we properly document and we have to go about, it will take a huge number of days, weeks. The steps in this is we upload patient data from our hospital side, like everything will be de-identified. They'll give you a de-identified number, and we won't expose the patient data as such. It will be a de-identified data of what site of cancer, what site cancer it is, at what stage they presented, at what treatment was given here, and whether they are surviving or deceased. Like that, 4 or 5 data are given, and pertaining to each cancer, if we have any markers, the genetic study, if we are having a profile IHC markers, we have to store those data. Once we start uploading data, we'll come to know whether we can do any trials with our patients from pharmaceutical data, which is uploaded from the pharmaceuticals as clinical data from other side. The artificial intelligence in this will match the hospital-based data and the clinical data to check for any opportunity trials which can be shown to the hospital. From the opportunity trials, we have to select whether we have to see whether the trial is feasible or not, and we have to submit the data. Like this, we can share the data. So many patients' data are shared, and it will segregate how many patients, which cancer, which stage they have come. Everything will be shown, and the artificial intelligence will match with the data from the pharmaceuticals. Finally, the opportunity. So many trials can be done here like this. They'll give a report. From that, we have to take it 2-3 trials, and we have to analyze whether it is feasible in our setup. We have to analyze. Then we have to get the consent from the patient. After that, we have to proceed with the trial. Because there are many trials running throughout the world, but in India, it is very pathetic. Like we are not having many trials. And we are, after trial and FDA, everything is over only, we are getting the drug. So the long gap between the trials and the labeled drug is very long, and we are not utilizing the trial products, and we are losing many patients due to that. This is one dashboard what we are using at present, and it is an ongoing project, and they have a good backup, and they are doing many projects in Australia based on Singapore. They are doing many projects in Australia, India, and in many countries. Actually, if we have a good data setup, they are willing to concentrate more on India also. I'll tell that later. Then this is one new app and tool which was innovated last week and have got an award. It is .Plot. It is an at-home breast health monitoring. As I told that self-breast examination, I told no. Even though how many times we teach them, I have put in the slide, many of them will not be confidently doing it, or many of them are not going to, not practicing. Almost we could not follow them, and most of them will have a feedback like they can't confidently do on them. So this device uses sound waves to detect lumps in the breast, and it will map on the torso. based on the size and shape of the breast, it will map where, how much density, everything, it will get mapped. And the app will guide the woman to where to get the scan should be done, everything will be, app will be guiding the woman. And the scan data each month will be compared with the previous month's data. So to check for any changes, anything to be notified to the doctor, everything it will be done. So the main idea behind this, the innovator once had a breast lump. So she went to a doctor and they told monthly you have check yourself and you monitor yourself. If there is any change in the lump, you report to us, they have told. But later the lump got disappeared. But that innovator Shefali and Deborah, they thought why there is no proper assistance for this, and they took a survey to see how many women are doing self-breast examination and how confident they are. But they found out that most of the women are not confident on doing themselves the self-checks, and they have to report to a doctor even if it is a small problem. And so they thought to develop a device which can help in this monthly check. And it is a good thing. Last week, they got the Wayne James Dyson Award 2022. It is like this, a small unit which can be held in the hand like this. And the app in the mobile will show where to move the probe so that you can see the density. It will take up the data and it will analyze with the previous month data. Those data will be matched with other used data so that any irregularity from normal will be notified to the health consultant immediately. So this is one important innovation, like 10 days back only I got to know. So I don't know how it is going to come in market, but it is the thought process, like how we can do research in various things, how we can do things in planning and execution, like thought process should be there for prevention in mainly. Okay. So then one thing in artificial intelligence, radiation oncology, how it is utilized. So RadiPlan is a very good thing, and it uses artificial intelligence, which increases the accuracy, personalization, and efficiency of RT delivery. The target is located, and it can surely target the needed cells that have to be destroyed. The multi-parameter optimization is done. It is a head and neck cancer where the target is targeted, and see how the other tissues will be protected so well. Previously, we can't assess how the neighboring structures are getting affected. Now, the neighboring structures, how much dose they are receiving, that we can monitor, that we can reduce. The target, the tumor site, how much dose should be given, everything can be at pinpoint, and it can be increased or decreased accordingly. So it is like this. So everything used is data from the AI. So this is how we use. So artificial, then it is also used in breast cancer diagnosis using ultrasound images and grid-based deep feature generator. So in breast ultrasonography, the image recognition task is much used by the AI, and it gives good quantitative assessment. Automatically identify the image data and reports to alert the radiologist. The machine learning technique is used and proposed a strategy for analyzing benign and malignant breast tumors, and it can perform well in identifying whether it is benign or malignant, or in between whether it needs biopsy, and the unnecessary biopsies are protected. So it enhances the diagnostic accuracy and minimizes the needleless biopsy for breast cancers. So the short-term goal for real-world data can be to define policies and workflow of routinely linked trial data to cancer and mortality registry data, as well as develop infrastructure to secure and sensitive data. The patient-reported data short-term goals can be expand the use and functionality of current developed patient self-reporting application. For correlative science data, it should develop protocols, data for collection, processing, storage, and analysis. For clinical trial, it should be more planned, collected, and organized and analyzed. So the long-term goal should be for real-world data, It's a complement, should be a complement for clinical data to allow long-term follow-up and economic analysis. For patient-reported data, it is to capture different dimensions of patient outcome and provide useful knowledge, support, feedback to the patient. The patient-reported data should be validated much because the point at which they're satisfied, how many times they're visiting the hospital, like after treatment, the survival of the patient with the cancer diagnosed, everything matters. The data should be prolonged as long as they live. And the correlative science data should have like standardized and shareable digital data bank, including different correlative data with different cancer types. And clinical trial data should be standardized, and it should be scalable, and everything should be, the standardization should be improved a lot. So, as such, the data science in cancer research can be used in diagnosis, early detection, prevention, biomarkers, prognosis prediction, personalized and patient care. And in trials, it can be used in biomarker discovery, adaptive trials, meta-analysis, clinical trials and real-world data, data sharing, and we have to do better at whatever we are doing. We have to improve. In each step, we have to improve. So what are the various challenges we are facing? The data, the managing the huge volume and the velocity we have to manage. So adopting a problem solving approach and understanding the tools and technologies to choose the right analytical tools and keeping with latest advancements. So integrating and interoperability of the data originating from different systems and sources, because they will mismatch everywhere, it will not be uniform. So uniformity should be maintained. The most important thing in data is the data privacy and protection. The confidentiality and the patient identification should never be told. It should be masked, and everything, whatever we are submitting, should be de-identification. But in genetic study, when we go as such, when we come back, it should be the patient genes should be identified at some level. So it should be masked in some way, like everything can be tracked at whatever level they are getting treated. And getting staff with correct skills for the correct work is still a problem. And a long-standing challenge is the insufficient availability of massive data for incorporating and putting into database. And in our country, cost is one of the important factors to proceed with these things. So coming to scope, in medical image analysis, there are advanced techniques to enhance image analysis to detect abnormalities, deformities. It is one of the most important field, the radiology. So AI, like everywhere it is booming up, and teleradiology, everything has improved. Wherever do the scan, we can report from here. Sequencing with artificial intelligence technology. So it's booming up a lot. And then natural language processing of narratives, which extract annotated data from unstructured clinical text to gain more insight into the overall patient care and experience. And monitoring patient health using wearable devices, symptom reporting, etc., can help the physician monitor better. And then the social media, where we can target a wider range. Now, the social media, like whatever we are using in India, it has a huge chance for creating awareness and prevention. So the way we are going to utilize it should be researched properly, and we can reach the grassroots level for creating awareness using this social media. The virtual care, which is the comprehensive platform to support patient care, self-monitoring and online assistance. So you can think of producing a model which is suitable for collecting basic data from all grassroots level. So it should be simplified, and it should be understandable to low-level persons also, so that we have to get data from all levels. Newly diagnosed, screened population, treated, targeted population, follow-up patients. So everything should be compiled, and we have to have a data. If any one of you have the idea of taking this project, definitely will help and collaborate with you. OncoShot also has told that they will support, and this is the basic thing, because we are in Chennai. So here I'm seeing some data workup is done like that. When we discuss in other areas and all, they don't have proper setup for segregating data. Even they have all the patients, variety of patients, everything, but no proper follow-up of those patients. The quality of data, whatever they have, is very poor and mismatching. So there should be a proper tool which can take data so that from the data we can follow up, the prevention activities can be done, and we can show some change in the projected incidence number. And an app for awareness and risk identification. As there are already many apps are there, but more simplified, easy accessible, and it should be properly propagated and advertised so that it reaches all levels, so that they themselves can get analyze their risk. If they are higher risk, they will approach the doctor immediately. So it should also be properly propagated in social media, and you can have an app for treated and follow-up patients. Because once getting treated, patient will think that's all. They won't come for follow-up. So once actually cancer after treatment, once in a month for 6 months, they'll come for follow-up. Then once in 3 months. Once in 6 months later, till 2 years, they will be coming once in 3 months to 6 months. After 2 years, once in 6 months to 1 year, they will come. After 5 years only, they will become survivor. So till 5 years, they should be monitored properly. But most of them will be missed with the follow-up. Because the chances of recurrence of cancer in the initial 2 years is very high, and within 5 years, it's high. So this is the crucial period the patient should come for follow-up. They should never mix up the follow-up, because we can easily detect if it is recur and they can be treated. If the recurrence is there and they are not coming for treatment, it will be prolonged and it will go to the next stage. So the treatment given will be of waste. So proper follow-up should be there. An app for those patients can be done. So these are the various ideas we have put across, so that from your point of view, if you think and suggest, we can help you with how to proceed with these things. So in an ideal scenario, a comprehensive collection of cancer patient data should include both data derived from the patient. It can be demographic information, familial history symptoms, comorbidities, histopathological features, immunohistochemistry, nucleic acid sequencing, biochemical analysis, digital images, experiment measurements using digital devices, but also results from these things, patient data, but also results generated from the application of AI. So it should be an ideal scenario. Then we have to proceed with the methodology for treating the thing. So in future, the next generation of treatment for cancer may be found not by the scientists peering through microscopes, but by computer scientists with the help of medical fraternity. They'll crunch the cancer numbers. So thanks to the unprecedented amounts of data what we have, and we have to still improve on the volume of the data in India for its population. So this work allows them to pioneer new diagnostic tools, generate novel therapeutic treatments, and significantly advance the fight against cancer. Some of these advances may even allow oncologists to harness a patient's own immune system to fight against cancer. So in the future, when a cancer patient comes in, they are going to be able to monitor the genomics of their cancer. At the gene level, we are going to have a data in real time to make predictions about the course of a cancer might take, and to make real-time decisions about what therapeutics to use. We are not going to have to wait and see if they respond. We have to wait and see for 3-4 doses and then see whether they are responding. It's not like that. So first is digital, we'll check the genomics and we can know how much percentage they're going to respond to the treatment. So accordingly, we'll plan the method of treatment and then change when they toe fall along in treatment. So in my conclusion and my perspectives, cancer is a disease that exhibits features of complex system, example, self-organization, emerging patterns, adaptive and collective behavior, nonlinear dynamics. Computational cancer research is a multidisciplinary area aim to advance the biomedical understanding of cancer by harnessing the power of data analytics and AI to advance in both basic and clinical settings. With the rapid development of precision medicine and big data application in cancer research, artificial intelligence is setting down exceptional opportunities and ambitious challenges in this area, facilitating the progress toward individually tailored preventive and therapeutic interventions. So for this is for your data science part, and for awareness, my take-home messages are: don't smoke, please don't smoke, quit smoking, stop drinking alcohol, eat healthy diet, exercise, maintain your weight, decrease your screen time, have good sleep, don't stress more, be aware. So please get screened at correct age. So don't Google for your symptoms. Almost all are with computers, so you'll be Googling. So for any symptoms, if you Google, it will totally mislead. So please don't Google for whatever I told, and don't go in a wrong way. And whatever awareness you had, please spread the awareness of the self-breast examination, pap smear, mammogram, vaccination. If any doubt, you can ask me. And definitely in your home, in your neighbors, with your classmates, please open up, break the barrier, please open up and talk to them, men or women, both. Like with the symptoms, I can't segregate, like you can't discharge. Any man should ask her wife or any wife discharge any lump. It should be open discussion at home, so that they'll come out and they'll go to the doctor at correct time. So in this cancer journey, as a preventive oncologist, I want, there are more chances in prevention activities for you, and the data collection is the main thing, so that we can focus on which cancer and which area we have to focus for prevention. So please, all of you think over it, so that, because India population is exploding at a fast rate, we are going to beat everything. And with this exponential rise in population, we are going to have many cancer patients also, along with other diseases like diabetes, everything. So when we are going to face a so much huge number, and due to this COVID also, for the past 2 years, we didn't have any much of screening activities. Already it was not much. So never patient turned up for screening. So prevention, screening, everything was badly affected for the past 2 years. And with the population increasing, so we have to put our mind across it and think over the prevention strategies, screening thing, so that we can at least do some to the population, like we can detect at the early stage or prevent certain cancers. So diagnosis, treatment part, there are high level of research aspects in it. You can take over this. And in the survivor also, as I told, the follow-up of the patient is very important to have much more data to analyze them, as we are seeing many second primaries also, second cancer incidents also is we are seeing. Okay, so prevention is better than cure. So concentrate on prevention and screening thing more. Then later the novel technologies for treatment. So I extend my thanks to Dr. Alok, our CEO, and Professor Rajsundar sir, our director, our department director, oncology, Dr. Dinesh, our research head, Hyderabad, and Dr. Nilesh, OncoShot India partner, and Dr. Prasanna, my husband, and Mr. Tirumurugan and Radhe, my brother and sister, who gave me knowledge on these things and made me do this, and Mr. Arun and Aarti, who are artificial intelligence and medical labs developers. Thank you. So let's both join hands and beat cancer in whatever way we can do it. We'll do it. Thank you.
Thank you very much for your wonderful and thought-provoking and very important. All of you should give listen for screening and other things. I think you have created awareness. Thank you so much, ma'am, for your valuable input for the past 2.5 hours for our audience. Now I request the audience to
please, any suggestions, anything you can.
Yeah. So you've given up, open up a lot of avenues, ma'am. Our students.
Yeah, because there are much things can be done here. From your aspect, you can do much things, and now only we are also coming out with ideas. So please catch those points and do it. We have access now. We have access, and we have many contacts to do it.
Yes, ma'am. Our students are working on like lung cancers, and they're collecting certain group of data, and they will be focusing on the features, what is to be extracted. And sometimes people might not be knowing which factors will help them as a computer scientist. In that scenario, I think you people can help us what type of features could be extracted, and we can work on it to model, CNN model, like convolutional neural network model and other things that might give the accuracy level of the increases the accuracy level of whether it's a cell is a benign or not. That could be done, ma'am. The feature selection is very important in our aspect.
Yes, madam. And that's early detection aspect, some prevention, the pre-cancerous stage, what I told for cervix. In oral cancer also, we tobacco is one of the main important factor. This human papilloma virus is also one of the causative for oral cancer.
Okay.
So from saliva, they started extracting and detecting HPV. They'll have high chance of getting oral cancer. So these things are coming up, and they have the product should be patented. There are much more area in research on that also. Human papilloma virus in oral cancer, because it is not at all documented. Everywhere we think only tobacco as the cause, but we could see many cases without tobacco, human papilloma virus causing oral cancer. So it is on one aspect, you can do many things from saliva, secretions, those things can be analyzed, and light illumination, those oral ulcers, no? We have a study with that oral ulcers, infrared rays when passed, that luminosity they are detecting to check whether it is benign or malignancy. Many research are going on. And for breast, using the breast temperature, breast tissue thermography utilized. Breast temperature is analyzed, and if some area is warm, that area need to be absorbed more. Like thermography is utilized in breast. Like that, if you take the thing, the prevention and early detection is the main thing you have to concentrate. This genetic aspect, whatever you are telling, no, madam, the genes, whatever you are telling, it's an next level, and it is diagnosed and treating patients. So there is much more scope in prevention and early detection itself. If they concentrate on that, it will be much worthwhile because of the huge population here.
Audience,
how can we get data? What data? So it is like we have data mainly we are giving to Cancer Institute and DPH, Department of Public Health, is having the cancer data there. Their compiled data they released up till 2016, everything is compiled. From 2017 they are compiling now. It is for our state, I'm telling, Tamil Nadu statistics cancer registry is 2016 till it is compiled. 2017 on compilation they are taking till 2016 it is there, released data is there. There are web links, and you can approach Cancer Institute Epidemiology Department. Any questions? If you ask questions only, I can interact, no, madam. Any suggestions of research in prevention and screening aspects? Numerical data for uterus cancer suggests some ideas. Like Tamil Nadu data for whatever cancer till 2016 we have good data. Compiled data is there. You can if you search you will get, like cancer registry TNCRP. If you browse you will get the data. Tamil Nadu Cancer Registry project. You browse and see. If you're not getting, you can approach me. That uterus cancer also, uterus cancer is endometrium cancer, cervical cancer. So uterus cancer, what you want, you have to correctly ask. Any other questions? Any teachers or professors, can you give your like suggestions or discuss something? I want some professors to address my some.
Participants.
Actually, half an hour at least we have to discuss because such a huge topic we have given. So
Yes,
students, please utilize this opportunity.
Dear ma'am, I'm Dr. Minnie from Madras Christian College,
Okay,
the
madam.
Department of Computer Science. Your session is extremely interesting and thought-provoking, ma'am. Is there any possibility of our college collaborating with you? And see, we have a good team of faculty members doing research in data mining, AI, say in image processing, natural language processing, and so on. So is there a possibility of collaboration? In that case, how to contact?
Yeah, it's there, madam. Like that on-shot trial and all what I was telling, no, madam. That project is ongoing project. They have offered like if any student is interested on data collection from grassroots level, if they have any idea of forming a tool so that we can have a good data from all levels. So they have suggested me to tell that if any students is representing for that, we can collaborate. Definitely we can collaborate. We have to do something for that.
Thank you.
How can we combine wet lab work like isolated mRNA? This is totally data science. I can't help much on it. Like combined wet lab, that question, it's totally on your part. I can't go into depth on it. Next, is 3D mammogram effective for breast cancer prediction? And most of the thing what we are using only digitalized mammogram, full field digitalized mammogram only we are using, and it is the most effective for breast cancer prediction. Now we are using computerized tomography in the sense the slices will be more, so that each slice can be analyzed and in depth the tissue level at various level can be studied. So it is a full field digital mammogram with tomography. Now they are replacing.
Any other questions from the audience?
Now, how many of you think like screening, how much effective, like in this population, whoever is attending, I don't know how many of you are above 40 or above 30 like that, but screening knowledge level or awareness level, if I give you a score of 1 to 5, how much it could be, madam?
So everybody, I think for me, ma'am, immediate 4, maybe the maximum.
Maximum. But even though awareness is there, no, they're not going to doctor and having the test done, no, madam. They'll postpone. That is the real scenario, no, madam.
Yeah, it's true.
It's
in all
true.
the places, I think postponement there, ma'am, but awareness is important. I think we can have the camps and other things, and we prefer people to do that.
At whatever educational level, at professional level, the time postponement is the main thing. Even they will be aware regarding everything, but they will postpone, keeping on postponing things. So actually, the foreign Western countries, it is like insurance is covered at that time. If they have to do the pathway, they will do. If they are giving the appointment for mammogram, they will do. But the main drawback is they don't have any insurance coverage or anything for this. And even if we do free, also they are not coming with the awareness. Some barrier is there which we have to break to bring the population get screened. Is frequent urination a symptom of breast cancer? No, it is it is not a symptom as such of breast cancer, unless if it is metastasis from breast cancer to bladder. If something is metastasis, like spread to breast cancer, spread to bladder, urinary bladder, they may have, but directly it is not a relation with frequent malnutrition. It is not clear when you say about data collection side till. Yeah, like we have the TNCRP data compiled in the sense for every district, how many patient of what cancer. So for each district in Tamil Nadu, we have a map and we have the correct numbers till 2016. After 2017, they are compiling. Till 2016, everything is in Atlas. How much percentage of cancer in each district, head and neck cancer, oral cancer, for each cancer with numbers till 2016, it is there. We have the data. It's a compiled thing, means it is segregated from various hospitals, from various registries. They have registers to collect data from each district. 5 district is under one person to collect data. They'll come to us and they'll have the data. Now they made it as online. We have a dashboard also. TNCRP, Tamil Nadu Cancer Registry Project. P. You see that if you're not getting it, you can get back to me. You can ask madam and contact me. TNCRP. And it is recorded by the government also. Whatever we are giving data is patient age, name, address, phone number, everything we have to submit so that they will track after 2 years whether the patient is alive. Everything will be tracked from the registry itself, because once they are death also, we can't, if they are not reported properly in the hospital, if they are dying also, we will not come to know. So they will track each year whether the patient is alive. Everything is done there. Our registry is stronger than other states.
Any questions from the audience?
Thank you, ma'am, to get the real-time data of liver cancer. Actually, we are in a corporate setup. So I can get yourself introduced to the liver department. So you can discuss with them. Real-time data, I don't know how they'll take it. If you want to have a discussion, I can plan and arrange. Because real-time data for research in corporate, how they will take up, I don't know. Better you can go to Stanley like that, because the liver department are very good there. So through university, if you approach Tamil Nadu Medical University for research purposes, they can link to government hospital. Stanley and all very good in liver. What are the challenges in cancer detection which you feel still unexplored? So cancer detection per se, for many cancers, the early stage and pre-cancer stage, we are there. We are doing tests, but still now the breast, what they have doing the dot plot, even then it will not, when they handle, it will be like some size only it can detect. So we have to think in depth, like that 4 millimeter lesion will be detected by screening mammogram. The patient should be correctly coming for screening at that stage. That awareness should be there and the barrier should be broken. And still that colon cancer, those things can be checked with many blood tests or saliva, like HPV in salivary secretion. There are many things that can be explored for each cancers in that path with the risk factor and etiology. We have to explore on that. Yeah, TNCRP. So whatever you got it from this session, please, the awareness part, take it into your mind. Please, regarding the self-breast examination, mammography, pap smear, you have to definitely spread that to the other females.
Any other questions? Thank you very much for spending your valuable time and brainstorming session, ma'am. We had a very good brainstorming session. Takeaway is screening and other things to be done as per we have created awareness, and definitely our participants will spread over all the females, and we will help the society. And according to the opening problems which is given, they will be taking up seriously from our teams, and we can collaborate with you, ma'am. Thank you so much for your valuable session with your valuable time. By spending your valuable time without hesitating, immediately you have accepted my invitation to spend your valuable time for many days. You have prepared and you have done a very good job, ma'am. Thank you so much.
If anything, I have blundered on data science, please excuse me, because I'm not into depth of it. I had 2-3 classes on that. Then only I went through that. So if anything major wrong, please excuse with me. And on the other part, like if anything you want to discuss with me, please approach madam. She will give my contact number and mail ID. I'll discuss with her. Definitely I'm open up to trials or any suggestions, or if you need any treatment part, any diagnosis, screening, whatever you want, camp, anything you can ask madam. She will give my number and mail ID. Madam, please, you can give my number or
okay,
mail. No issues. I will keep touching with them, and we will discuss each and everything. So like 2-3 times if we discuss, we can definitely come out some good projects. We can come out, I feel.
So let us prepare one app, ma'am. We will try our level best to get the best app for our.
There are many apps for periods, PCOD, many things have been there, but still, if you can explore more on it with perspective to female health, and this tobacco for gadgets related itself, to cut short the screen time, they have app. So for tobacco also, you can, to restrict it, you can have an app, I feel. It's my suggestion. So how it can incorporate it, you have to explore.
Okay. Thank you so much, ma'am. Let us have a vote of thanks now.
Thank you.
Thank you, ma'am, for sharing your precious thoughts to the audience, and I'm sure that they enjoyed listening to your area of expertise. This end of the session is just beginning of another. Learn to the best part is always yet to come. Now I would like to call upon Miss Yasmin Bono for vote of thanks.
Good evening, everyone. It's been a very fascinating and engaging session. No person was ever honored for what he received. Honor has been the reward for what he gave. So it's our pleasure and honor to thank our Honorable Vice Chancellor of University of Madras, Professor Dr. S. Gauri, sir. It's important to be a person of honor than to be a person with wealth. As an ideal to this, I would like to thank the dynamic registrar, Dr. S. Erumale, sir. Excellent is not being the best, it is doing your best. In that way, my heartfelt thanks goes to Professor Dr. N. Madhivanan, sir, overall coordinator of RUSA 2.0, Research, Innovation and Quality Improvement. The person who never dreamed about success, who worked for it. So it's my hearty gratitude to the pillar of project support and coordinator, Dr. E. Murugan, sir, professor and head Department of Physical Chemistry, University of Madras. To be inspired is great, but to be an inspiration is an honor. As an inspiration to many, my sincere thanks to the captain of the ship of the project, Professor Dr. S. Balakumar, sir, Director of National Center for Nanoscience and Nanotechnology, University of Madras. Now I would like to express my gratitude to Dr. S. Rajeshwari, ma'am, Senior Consultant, Preventive Oncologist and Colposcopy Specialist. Thank you, ma'am, for the wonderful methodologies with real-world examples, predicting early cancer stages, screening test, and awareness about it. So you motivated and encouraged young brains to pursue the research and contribute more for the healthcare in cancer. So now I'm very glad to thank Professor and Head of the Computer Science Department, Dr. P. Tangavel, sir, for his support. My sincere thanks goes to Dr.PL.Chithra ma'am, Professor and Head in charge of Department of Network Systems and Information Technology. I also want to thank and extend my great generous thanks to the principal investigators, Dr. M. Sornam ma'am, Dr. B. Lavanya ma'am, and Dr. S. Gopinathan sir for their kind support. Also, I would like to thank all the participants, PG students, and research scholars, specifically Bhavani, for your extreme support for this webinar, and all the guest lecturers of Department of Network Systems and Information Technology, authorities and staff. Thank you to all the esteemed delegates of the webinar for their presence and contribution to make this webinar a great success. Once again, thank you all.
Thank you, Asmil. A good event never ends in the world. They take only a pass and keep us waiting for the next. Thank you all.
Feedback form will be shared now. All of you fill it up, your feedback form. Your certificates will be received within 2 days.
Okay. Thank you, madam. Thanks. Convey my thanks to all professors, madam. I don't know in name by person, but you convey my thanks and regards
Yes,
to
ma'am.
madam.
Ma'am, whatever you have done in data science, everything you have brought out very nicely, ma'am.
Sure, madam. Okay.
Nothing is wrong, ma'am. Everything is very clear and it is useful to the research, ma'am.
Sure, madam. Thank you, madam.
Thank you so much for your valuable presence, ma'am. We will keep in touch and we'll collaborate, ma'am.
Okay, madam. Thank you, madam.
Thank you.
Thank you.
Feedback form. Yeah, feedback link will be shared now. All of you, all participants, kindly fill up your feedback.
Thank you, madam. Shall I leave, madam?
Yeah. Thank you so much, ma'am.
Feedback link ma'am.
Yeah, we will send it. We are sending it.
Okay, no problem.